our members, our call center members, will be able to respond. And on the other hand, in terms of services for inpatient and certain specialized services, we also have a 24-hour team of case managers who would be on hand to do the pre-authorizations. And I must say that some time back, there was quite a significant delay, but right now, within hours, at least within 24 hours for emergencies, the authorizations are actually done on time, because we have a dedicated team of qualified healthcare personnel who handle this on a daily basis. So should anyone have challenges, please feel free to reach out, but because we are here to assist you to access care in the easiest way possible.
Okay, I want us to put the shoe on the other foot as well and talk about the insurance fund and the challenges they're facing in terms of giving their services to their citizens. You've spoken about sourcing of funding. You've spoken about fraudulent claims as well. Is that top on your priority list in terms of dealing with the challenges with the insurance fund?
Yes, absolutely, because from what we are seeing, and even very many studies done, it is estimated medical fraud is about 20 to 30%. And if you look at what we pay out annually, that is a significant amount of money that, if it was not fraudulently consumed, would go a long way in helping more people access more services, as you have seen us working towards improving access to the services. And here we would need a total cooperation of all the key players, because many times this fraud does not happen in isolation. You'd find that the member would collude with the healthcare provider, who might even collude with those people you're calling cartels internally. So we must work together to eliminate that, because it is a huge waste of resources and basically potential benefits to our Kenyan people.
When it comes to the status of NHIF enrollment in the country, where does it stand as of right now?
In terms of enrollment, okay, I'll probably say this and repeat something I've said earlier. Up to now, we have 9.6 members, principal members in our database. This means, which is about 22.5 million Kenyans, about 43% of our population, meaning that these are people who have joined and accessed benefits. Now, unfortunately, some of, especially the voluntary contributors, about half of them, or more than half of them, actually way more than half of them, are not active members as at this moment. So step one in terms of moving forward is to ensure that these members pay for the services. So the challenge that we have, and this is, and you mentioned, I should mention the challenges we have as insurance, is this group of members who only join to access a service, then as soon as they've accessed the service, get out or do not renew, is a serious adverse selection that contributes to heavy losses, because the premium that is paid and the benefits that accrue, the benefits are so much bigger. So, and the principle of insurance is that the healthy support the sick, and because everyone is a member at all times, and not everybody will get sick. So that is how it balances out. But when we have a scenario whereby it's only the people who need a particular service coming in and then not renewing, then it becomes untenable. And that is what has led to massive loss ratios. So right now, we are working together with all our key stakeholders, including the county governments, to ensure that we pick the enrollment and also have mechanisms to ensure that members remain as contributors. So this can be through various forms, even obligating, tying them to licenses and all that. And this is conversations that we're having, because for ultimate success, we need everyone on board.
Okay, even before I get to my next question, we have a couple of WhatsApp messages in. Let's look at those very quickly and then come back to them, of course, on that right here. And don't forget, even as you look at that, of course, you can get yourself a copy of your People Daily straight to your phone. It's only 10 shillings. The number that you dial is *550 *4#. Once again, the number is *550 *4#. Dial that number and get yourself a copy of your People Daily straight to your phone. It's brought to you by the PD and Safaricom. You don't need any data for that. You don't need to get a mobile app to access your e-paper. Just a number, *550 *4#. As you get your copy and read about what they're calling a health crisis at this particular point in time, we have some WhatsApp messages that you have sent in. Let's look at them. If indeed NHIF will not cover medical bills for COVID-19, then hospitals will exploit this avenue to milk patients by faking their COVID-positive results. Okay, an issue of concern right there. Let's have another message up on screen. Why are those so-called NHIF care providers so expensive? You fill the form after getting treatment, but no provision on how much you'll be charged. How can a pair of spectacles, which cost 5,000 shillings, be charged at 23,000? What's wrong? Surely. That's Solomon from Meru, questioning the costings from NHIF care providers. Jeff asked the CEO, why can't they pay even 50% of hospital bills for their clients? Okay, some of those questions right there, and it's a good thing we do have the CEO of the insurance fund to take us through some of those concerns that you have. Daktari, I'll recap those questions very quickly. There's one a viewer who wants to find out in terms of how much is paid for their hospital bills. They're saying that according to their experience with the fund doesn't pay more than 50% of a particular hospital bill. Could you clarify on probably what happens in such a situation?
Okay, and I will also comment on the other questions, but let me answer that one first. As a fund, we have it would be good for people to know we have three types of contracts with hospitals. We have contract A, which is for government institutions, government hospitals, county hospitals, and then we have contract B, which is for faith-based organizations and some private hospitals. And for contract A and B, there we have contracted them for comprehensive services. What does that mean? It means that when you walk in, you get all treatment and you do not spend even a shilling. And that is where we have majority of our providers in contract A and contract B. Then contract C is mostly private facilities. And with these ones, the benefit that our members get is on the bed rebate. So that's why you might say that my inpatient bill was paid, half of it is because we pay a daily bed rebate, which is up to 4,000 shillings a day. And also for certain contracted services. For example, might be contracted for radiology services. So if you go there, you get your pre-authorization, you get your MRI done, or your CT scan done, or some of them or with certain surgical packages, and you go in and we pay for certain surgical procedures, you know, your hip replacement, etc., etc. So those are the three different types of contracts we have with hospitals. And when a member is going to a hospital, it might be a good idea to just call the call center and ask what is the expectation in terms of how much will be reimbursed. So that is what we have done. And it is interesting, and let me just mention this, the first two questions. I think somebody asked about, my spectacles. He knows that they are 5,000 shillings and they've seen the bill at whatever amount. This challenge is one of the biggest challenges we have, and that's one of the challenges that even insurance companies have. There's something called upcoding, whereby a service that is usually a low amount, by the time the bills are coming, they're higher, but we are looking at eliminating, and this is part of that whole suit of the 20 to 30% that accounts for medical fraud. And that is why we are encouraging our members in terms of our digital platforms that also register your number with NHIF, so that anytime you are billed, you actually get an SMS telling you this is the hospital that you went to and this is how much you are billed. And together this way would be able to contain those costs which are associated with wastage to be able to continuously improve on the benefits that we offer. Thank you. Back to you, Jeff.
Okay, of course, also there's a key issue of concern right there, and of course, this was being posed to you in terms of the NHIF care providers being so expensive. You've addressed that in terms of that possibly being upcoding. But also, I think it's a theme that's coming over and over again in our conversations, because another viewer asked the fact that if NHIF isn't paying COVID-19 bills, we are leaving Kenyans to, you know, medical sharks and open to exploitation. I think possibly this is the part where we ask, are we looking at a situation where probably in the future we have some of these costs as far as COVID-19 is concerned being borne by the insurance fund, or is this a hard no because of the status of it being a pandemic?
Yes. Thank you, Jeff. You see, it being a pandemic, it means that, even in a situation of a pandemic, if you look at even our Public Health Act, there are a raft of measures that can be taken to ensure that we cover for this. And for insurance, it is, you can actually end up having even COVID covered if it is included in the contract and if it is funded. Because even right now, we're working to see how can we even get some funding to be able to support. So it is all an issue of funding. And I would like you to understand, like, even for us, what we get is the contribution from our members, and that is all, and that's what we use to pay for the claims that they incur. But yes, indeed, and this, what you'd say, the disease treating us abnormally, we have a few learnings, and we're working towards ensuring how do we mitigate should a similar thing happen in the future. Yeah, what do we need to put in place to ensure that even that funding is available, even in the case of a pandemic? But it is good to realize that the biggest challenge with a pandemic is that doing modeling, risk modeling, to be able to predict is virtually impossible, because it is so widespread, and in this case, even unknown about what the evolution is going to be. But every day is a learning, and we move up step by step. And just like even the measures that the government is taking to ensure that even our frontline workers are protected, and funding that through NHIF.
We'll be talking about the frontline workers in a bit, even as we wind up this particular conversation, because above and beyond being a CEO, you're also a medical doctor. We'll be talking about that in a bit. But let's look at even best practice across the region, because when we look at sub-Saharan Africa, Rwanda having a lot of lessons the region can learn in terms of national health insurance, uptake in that. I think they're standing at above 80% enrollment. What are some of the lessons you're learning from the region, and how can we tap into those as well? We've seen Rwanda has a lot of community-based healthcare. How do we try and drive that more within our context to make sure that more people can access this elusive universal healthcare that we're talking about?
First of all, having more people. In fact, during these COVID times, is when you realize how much you even need having your NHIF cover, or having a medical cover for that matter, because we have seen what the effect that it has had on our economy. So we know that even the reliance on the Harambes or the Mchangos to settle hospital bills is waning, because more people are struggling in these economic times. So this is a time that you actually need your medical insurance even more. And looking at NHIF and the raft of benefits that I've described for you, which is it equates to only 17 shillings a day, yeah, for all those benefits, is something that we should. And even looking at the region, I would say we are also, if you look at the expansion and even the scale up for UHC, and even having that community-based approach with the community health workers, the community health volunteers, and looking at that framework that can be able to support primary care to ensure that even in our referral process, that the secondary and the tertiary facilities are not overwhelmed. So all that is already in place, and it's up to us to support by ensuring that we remain as members, and support to ensure that we eliminate that waste that contributes to making us not be able to achieve our goals. But yes, I'm looking at the regions and even looking at even other areas that are centers of excellence, and even in terms of achieving UHC. Like I said earlier, UHC is not an event, it's a journey. And even very mature ones like Germany, it took them 183 years to get where they are. But it doesn't mean that it's going to take us that long, because we are learning and we're using best practices. And we've also been on that journey ourselves. And like I started off saying, we've been on that journey for 66 years since establishment of NHIF. But right now, we are approaching the home run, whereby we need support from all corners and consolidating our learnings to be able to scale up to ensure that Kenyans have access to care without financial hardship.
Okay, we're approaching the tail end of this particular conversation, but before we go there, we have another couple of messages, this courtesy of WhatsApp as well. So if you feel you have a question, you want to forward a comment as well as far as insurance in the country is concerned, you can do that. The WhatsApp number is at the bottom of the screen. You can also get me at I am Jeff Mote or at K24 TV. Let's have those messages up, please. Most of the service providers have been crippled by the payment delays, which even when paid, they don't fully pay. Capitation is also very delayed, even today not paid. Okay, so an issue in terms of delay of payments to healthcare providers. Please let the CEO clear the fact that some facilities sent clients away, yet you chose the facility. They demand cash payment, yet you are the principal member. Okay. I'm sure he'll speak to that issue as well. I went to hospital and NHIF office told me to pay up to 2022 and I paid. Then I was told I have exhausted my money and I was going to get chemo done. That's chemotherapy. Okay, that's an issue of concern right there. A couple of messages coming in as far as that's concerned. Still with the CEO of NHIF, Dr. Peter Kamunyo. Dr. You've heard some of the questions being forwarded there as far as, provision of these services is concerned. Let's start with the fact that there was a message talking about delaying in terms of payments to healthcare facilities for a long period of time. And even when the capitation is paid, it's still really late. What do you say? What's your response to that?
Okay, Jeff. Indeed, there has been ups and downs in terms of payment of claims, and so a lot of this has also been occasioned by challenges of reconciliation, etc. And also, I'll tell you, there was a period where we were, when we had initially piloted the e-claims, and we found some challenges that caused some delay. However, for clean claims, and I can tell you, when we have clean claims right now, our turnaround time is between 14 to 21 days. Though our contracts talk about 90 days, but we strive to ensure that. We have embarked on a reconciliation of all our claims for since 2012, where it seems to be a challenge. And anyone who is experiencing any delays in terms of their claims, I would urge them to get in touch with their branch, the branch in charge of their area, to ensure that that is done. But we are striving, and that is the reason why we have reintroduced again the e-claims, to ensure that the transaction is actually recorded in real time. But one thing that I would say, we need to also, for the service providers, push for reconciliations, because many times we've gotten that feedback, yet when we go back, we realize the providers, they have even been paid, they've not allocated the funds that they've been paid to the accounts, or claims that had challenges, they were incomplete, have been returned to the hospital, but they have not yet addressed those challenges that were asked, because there is a certain level of due diligence that we also carry out on the claims, and not just pay everything that is submitted. So this is something I would say we must work in tandem to ensure that efficiency, because as service providers, they are the tool of delivery of our promise. So we value our service providers. They are our key. So we are working very hard to ensure that their payments are on time. And if there's a grievance, there's always a way to escalate to ensure that there's resolution of the same.
Okay, let's talk about that even as we wind this up as well. There was a grievance that one of our viewers raised, spoke about the fact that they hadn't paid some of their premiums. They were told to, make sure they've paid all of that. Upon doing it and trying to get service, they needed chemotherapy done, they were told their money has been used up. In a situation where there's this opacity and they can't understand how this process works, how do they scale up these concerns? How do they get this particular issue addressed? Where do they go to?
Yes, and actually, even by calling our call center, they would be able to have an escalation. Even through our website, you can lodge an issue on email. Even through the mobile app, you can raise an issue, and all this will be addressed because we look at all comments or issues that have been raised by our members. So, and also our case managers, quality assurance managers, even at the branches, if they can reach out, they can be able to get assistance. But I would like to urge that we also ensure that we remain valid members. So when we do have an occurrence, that we are able to access services seamlessly. Not to stay without paying, to be non-compliant for a very long time, until when something happens, that's when now you rush, you want to pay your premiums because you want to access a service. That is adverse selection, and that is one of the areas we need to work together to eliminate, so that we can be able to have a fund that is strong enough to support all the needs of our community.
Okay, we have a minute to go before we finally wind up this particular conversation. I want you to, remove your CEO hat of NHIF, wear your medical doctor's hat as well, because that's where it all began, Daktari. And we look at the front pages of some of our dailies today. Front page of the PD, staring at a health crisis, doctors planning to down their tools because they're not protected at work, and they're really at the front line. What's your reaction to this? Because these are your medical brothers and sisters. Some of them probably you are with them in school. What's your reaction to this particular state of affairs in the country right now, Daktari?
Okay, first of all, Jeff, the minute I took the Hippocratic oath, that will never come off. So I don't need to put back my doctor's hat on. It is always on. But indeed, first of all, we need to applaud the selflessness of our frontline healthcare workers. And here we are talking not only doctors, we are talking about the nurses, the clinical officers, the radiographers, the lab technicians, the support staff at the hospitals. They have been working tirelessly and obviously are being exposed, and in this situation, which is novel even for us. So first of all, I think we need to, as a country, applaud them and appreciate them in a very big way. In terms of ensuring protection, there's always safety first, and we are working towards that. And I think you also have the presidential directive that the public servants, the frontline workers, have a cover that would be able to support them in terms of their work injury benefits, in terms of their group life and group personal accident, and that is already on. And I think you'll be hearing about that in a short while. But indeed, their interests are being addressed, and because as frontline workers, they are the ones who are ensuring that this scourge does not spread, and that we save lives as much as possible. Thank you, Jeff. Okay,
I think that's where we leave it as far as this conversation is concerned. Thank you so much for making time to be on the show this morning. Dr. Peter Kamunyo, CEO, NHIF, thank you so much for making time. There's a tweet that has come in from one, Jeff Mutonga, saying, these are leadership-defining moments for you, Daktari. Godspeed to you and the work that is ahead of you.
Thank you very much.
Asante sana.
Thanks for the kind words. Yes.
Asante sana. That's why we end up this particular conversation, of course, as far as, the NHIF and the Big Four agenda and where it stands as well. Speaking, that was CEO of the NHIF, Dr. Peter Kamunyo, just speaking to the issues of the day right there. And don't forget, even as we talk about that, matters of health really front and center of what's going on. You can get yourself a copy of your People Daily, get that story right there on the front page, staring at a health crisis, they call it. Will they down their tools? That really is the question right now, because they say they're working at the front lines and haven't been protected. That's a discussion that is going on, and you can get the details of that story on page 8 of your People Daily, and you can get it straight to your phone. The number that you dial is *550*4#, and you get a copy of the PD to your phone. It's only 10 shillings, and it's brought to you by the People Daily and Safaricom. We take a short break right now. We are back on the other side as we get interactive. This is K24 This Morning.